Welcome back to the Winback Academy podcast, where we bring together voices from across our academy, clinicians, educators, and field experts, to explore how TechR therapy is being applied in the real world. Not just protocols, but clinical reasoning, cases, and integration into patient care. I'm your host, Dr. Ramona von Leyden, Winback's Senior Director of U.S. Medical Affairs. On this episode, we're sharing a replay of our Ask Me Anything on facial recovery, TMD and TMJ, peripheral facial conditions, and neural palsy. This discussion is led by Dr. Don DeFabio and Jesse Chalnick, PT, and joined by our panelists Grant Headley, Laura Ramus, Andrea Schwab, and myself as we explore clinical approaches to facial recovery and the integration of TechR therapy into patient care. Let's get into it. Welcome everybody to this month's Winback Ask Me Anything session. I'm your host, Dr. Ramona von Leyden, and each month we bring together clinicians and educators from across our academy to discuss real-world application of TechR therapy in clinical practice. Today's discussion is focused on facial recovery. That's TMD and TMJ, peripheral facial conditions, and neural palsies. Leading today's conversations are Dr. Don DeFabio and Jesse Chalnick, PT, and we're joined by our panelists Grant Headley, Andrea Schwab, and myself as we explore different clinical approaches to facial recovery and integration of TechR therapy into patient care. Don and Jesse, I'm excited to see what you've put together. Don, I'll hand it over to you to get us started.
Well, thanks, Ramona, and it's really exciting to be here and welcome everybody. And Jesse, it's going to be fun. We're going to hit some nerve palsies, specifically of the face and upper quarter, and then we're going to go into some TMD and TMJ. How to assess it, how to treat it, and how to get people feeling better, because it's, one of the highest proprioceptive centers of the body is the TM area, okay, that oral facial area. So when that's wonky, everything else is really off. That's why people with TMD symptoms are so variable: lightheaded, dizzy, ringing in the ears, brain fog, aches and pains throughout their body. So it's a real problem. However, you also have, because of all those nerves, that facial nerve gets involved. Now, Jesse, you have some experience in dealing with facial nerve irritations and neuralgias and palsies, right?
Yes, absolutely. So about a year and a half ago, I had a really interesting case of a lady that had come into me, and she was dealing with a Bell's palsy of the right side of her face.
Ooh,
And
let's
she
see
actually
if we can get
described
that
it.
up.
Yeah, pull it up for me if you can.
Yeah, let's see if we
Um,
can get that up for you here, because you did send me that. So there
and
it's
you'll see
us. There
if
you
anyone
go.
has a computer, you should be able to see it pretty well. It might be small on your iPhone. Hopefully you can like zoom in a little bit. But it was interesting. She described it getting this facial palsy almost 2 days after getting her COVID vaccine booster. So we know, like with Bell's palsy, there could be a viral impact. There could be some sort of environmental impact. There could be a mechanical impact that causes it. So this is what the patient associated with the possible beginnings of her Bell's palsy. So with that in mind, there was many things that I wanted to do in relation towards like flushing the side of the face, getting activity in the nerve to stimulate the muscle activity. But before I get into that, let me just kind of talk through a bit of the treatment parameters and a little bit of the differences that we saw over time. So anyone watching that can see a screen, basically this was 7 months of treatment. She came to me about 2 months after the Bell's palsy had started, and she kind of like lost hope. And then so each of these little frames, the 3 pictures at a time, are all a month in between. Left to right, they go smile, eyes open, eyes closed. So what you'll see, let's just go through the smile first. Obviously, over the 7 months, I don't have to describe it too in depth. We see right corner of the lip and the levator of the upper lip starting to lift, where by the end of the treatment in 7 months, she was actually able to give a soft smile, which for a patient dealing with something of this manner, to be able to be in a photo, be around friends, and give a soft smile comparatively to month one, where you smile and it's a completely asymmetrical figure, this was a lot for her. And then going into some of the middle pictures, these are eyes open. We see that we start to get eyelid lift within a month of the the first session. So I was doing 2 sessions a week throughout the months, 30-minute sessions. So it was literally within just a month that we saw change, and each month we saw change. So look through the progressions in the middle photo. Basically, what you're looking for is the eyelid lifting, whereas the end you see only about a 25% asymmetry just observably. And then the last one, looking at the right column of the pictures, you're looking at the eyes closed picture. And then basically you see by the third month of treatment, so this is her 5 months of Bell's palsy, we have the eyelid closed, which in the first two pictures you see like eye is flipping up, it's moving, but eyelid is not staying closed. By the 7th month, I would say we have almost complete eye closure. So just in depth, just looking at the pictures without even knowing the protocol, it shows that we were able to make quite an impact. The thing that they do say about Bell's palsy, though, specifically if this was exactly Bell's palsy, was the recovery time is so variable. You might have people recover from this in a couple of months, like 5 to 6 months, and you might have people going on for this for 3, 4, even 5 years and longer. So I think the amount of change we made, I call it about a 75% change in 7 months of treatment, pretty vast. So now let me go into some of the protocols that we looked at. I didn't necessarily find a protocol that we had been using with the win back to start, but I've been using what I had known from win back all along. Aspects I wanted to treat were the muscle tissue. Other aspects I wanted to treat were nerve stimulation and muscle, and then nerve stimulation from the motor and sensory aspect. So this was my protocol. I did 15 minutes of CET on one side of the face while I worked the RET at the same time. So I had the back four. So I was able to work it at the same exact time. The reason why I did both sides of the face was the aesthetic effect. If you look at her from slide 1 month, which would be her month 3, compared to her month 9, you see a vast effect in the aesthetics of her skin. So it wouldn't be fair to her if we only really gave treatment to one side, because the Takar current was also giving aesthetic effects just with the shallow settings I had on. So the CET was soft, about a medium, and then we played 20, 30%. If it got hot, sometimes I had to drop it to 15 to 20. And again, I was really just trying to get a muscle circulation, muscle flushing type of event happening with that. And then the other side of her face working at the same time, we did an RET current. It's going to lock you on deep because I wanted to use high tens and an EMS anyway. So I liked that it was deep. I grounded her thoracic spine. This was in order to run a current from her face down her cervical spine, where we have that branch of the facial nerve that kind of goes down to like the top of the cervical spine right in here. And then we use it almost like a focal point stimulator. So this was the image I had. This is what we used. We would try and stimulate the different areas, same way you would do with the focal point stimulator. But it wasn't just doing focal stimulation. It was doing a sensory aspect with throwing in high tens. It was doing an EMS, and then also the full RET, just flushing current going through. And then other things that I want to note before I involve like anyone asking questions or anything. So like we said in the beginning, the timeline of recovery for Bell's palsy, and I'm sure Don will get into this with some of his presentation that he put together, it's variable. But the cool thing was we saw inter-treatment effects. So what I mean by that is anyone that's worked with like a post-stroke population, trying to eat, trying to drink is very difficult for this population early on. So now take that into the Bell's palsy as it relates to their face. Same idea. Trying to drink and eat is very tough for this population because trying to close the mouth when you have water in, trying for a more viscous type of food to not slip out the side of your lip. So within sessions, starting from the 2nd month of treatment to the 3rd month of treatment, what she would report is the day of and the day after session, she would have the increased ability to drink from a straw. So within the sessions were about 2 days apart. By the 3rd day, she would notice it was much harder and the water would start to dribble out of her mouth. So I think there you can take away, okay, yes, Bell's palsy kind of writes itself, if we want to say that, in a matter of months. However, using Takar therapy, we're able to see after the treatment, the effect was that we were able to do something like drink water and hold it in our mouth quite a bit more. So I know this was a little long-winded Bell's palsy on one patient, but I think she has a really cool, shareable story. She's a cool way to kick off some interest in this. And yeah, would love to hear about anyone that had feedback in treating Bell's palsy and treatment guidelines that they had used or questions on the guidelines that I had even used.
Jesse, you said a lot of really, really great stuff. But right out of the box, you know, the standard of care for Bell's palsy is okay. It's Bell's palsy. Here's some antivirals. Here's some cortisone, and it's self-limiting. It'll go away in a couple of months. And when it goes away in a couple of months, oh, that's great. The patient's happy. But when it doesn't, you end up with what you walked into your practice. And that's a huge, huge problem. I think what we need to do, you need to start these people as soon as possible. So when you hear
Yeah.
Aunt Sally or my wife or my sister's friend had Bell's palsy, you get them in right away and you get them started on the tech heart because that really does make a difference, you know? And back in the day before I had this, we would just have them in the mirror making those funny faces. Day one, standard PT, because once they get this, this is amazing that you've achieved this. This is amazing because when those people are 8, 10 weeks out and the nerve hasn't been working, their chance of getting full recovery diminishes significantly. And I don't know if because I've dealt with this before, Techar. It's hard. It's hard. So
Yeah.
kudos, man.
Appreciate that. Yeah, a lot of my experience, actually, I had two experiences before this, before I was even a part of WinBack, where the best end of care I had was, again, looking in a mirror, just like you said, and we had a focal point stimulator.
Yeah.
And to say that we had this type of result, not even close.
And with the stroke patients, hopefully this will end up very soon out because I'm going to film it this week. She's a patient now, 6 months post-stroke, and she's functioning pretty well, very well. We just got her to a wide cane from the 4-prong cane, just a wide base cane. But she mentioned about swallowing, like you were saying, one session in her mouth and she felt she could chew and swallow better. And the session lasted 2 days. She came back 4 days later, said, I was good for 2 days. So I'm seeing that same thing with my central mediated neural dysfunctions, let's call them, that it's lasting about 2 days. And if we're going to get that neuroplasticity where it starts to develop new pathways and it lasts 3, 4, 5, and they beat it totally, time will tell. But that window is very small with these people. You can't wait weeks and months, you
Absolutely.
know?
Absolutely.
Jesse, I have a question for you. I love that you use the focal. Now you have on there a range from 3 to 10%. I think the focal, the points and through the face can be really sensitive. What would you say is probably like the upper limit in terms of the intensity for a patient with Bell's palsy that in terms of your experience?
That's a great question because it was very variable and it changed over time. So there'd be times in the beginning, like month one, where I would put like a 10% or a 12% on some of the more massy areas, like her cheek, the masseter over there, and she might even feel anything. And then I was like, all right, let me just inch it up. And thankfully, like that was around the time when I think the update happened when you're able to change it by a percent. So I was like, let me just inch it up a little bit. So then pretty much where I would get in that early phase, because you wouldn't feel anything and there was no activity, was like a 12-ish percent. But then when I was trying to do like some of like the frontalis muscle, a little different. Like it was more of like a 3%. Anything more, it's like you almost feel like you're getting a headache. So it was a lot of like patient feedback, and like obviously I could turn up the percentage on a more massy area. And then as I went up, okay, is this too much? Is this uncomfortable? Actually, you jogged my head about another thing that we had to kind of work through as well. Sensitivity around the teeth was interesting. So doing the CET current never had an issue like going over lip areas, going over chin areas, around the mouth. Doing an RET current, focal and high tens, gives the patient a feeling of like cold, like to describe it, like cold water running deep in her teeth. Very uncomfortable. So like these were sometimes things that, okay, if I adjusted, maybe I used like a bracelet, I turned off the EMS, I was able to get closer to her mouth and still work a high tens for sensory. But yeah, working on the face as well as working on any part of the body, it's cool because the feedback is so quick you can get from the patient and you can adjust so quick. So her levels are 3 to 10%. You may find in someone else it could be different. I would say with the face, in terms of using the RET focal stimulator, not necessarily just the face attachment, the RET focal stimulator, you're probably not seeing above a 12%. So we were on average 3 to 10%, shallower 3, massier 10.
You know,
Awesome. Thank you.
great stuff. Andrea, good question. Maybe you should just kind of decipher that for any new users we have, all that terminology, because you understood it, I understood it. But, can you break that down a little bit for some of our newer users, or maybe people are just checking TechR out for the win back for the first time, what all those terms mean, the CET, the RET, the percentages.
Yeah,
Andrew, you want to
absolutely.
go
I
in
mean,
or?
the capacitive current is really the one that you want to use in the beginning to prep the tissue. You're really improving that circulation. The RET is for the resistive current. That's the true TechR. That is the one where you're going to see a lot of that cellular metabolism accrue. Remember that TechR current occurs at the biological and cellular level first. And so from there, we get the tens. The tens is for that analgesic effect, that 25 hertz. So, one of the reasons why, Jesse, you saw that kind of aesthetic effect occur in your patient and why you had to work both sides is because it actually stimulates the superficial skin. You'll see a lot of skin tightening. So, from an aesthetic perspective, you'll for sure get a lot of that superficial stimulation, but we get that analgesic effect, that decrease in pain when it comes to the tens. In terms of focal, you really want to, focal is really great for stimulating areas that go a lot deeper. And in this case, like you guys use it for the motor points in the muscle, and the motor points is where the nerve inserts directly into the muscle, and that's great for stimulating it at its like max capacity. So I think in terms of like approach, this is a perfect blend of all of the variability that Winback Techer has to offer. So great job.
Well, no, thank you. So here's what it looks like. Different patient, obviously. Um, and what's cool here, this is the side where the palsy is, but you can see how those nerves go over. So that's why thought you were gonna say, Jesse, why you're working it symmetrically because of that neural overflow.
Yeah,
But
for the coca.
regardless, you can see he's only 3 to 5 days in. Okay. We
Oh,
got
wow.
him in right away. Um, and this is what we did. We went right after it, have the ground plate on his back, and we just went right to the RET with the high EMS. We had a little bit of high tens or some tens in it in the first couple of sessions because he did have some pain initially, but but that went away quickly. And that's the palsy. In addition to that, I also did some bracelets on him as we worked so because I was finding those hot spots. I was finding he couldn't tolerate the large surface area as much. There's my settings. So we can go back a little bit. So 20% on the RET resistive and static 2 with the high tens. But I found with my fingers, it's all right. That was a super hot spot when I was using the regular RET lead. So I found this was a little more palatable for the patient. So were you doing any bracelet work, Jesse?
I did. So, like, if we think it was like I was very centered in my treatments at that time for 30 minutes, and I was really doing as much trying to get EMS when I was doing RET. Um, but there was definitely days where I probably like would maybe spend the last 2 or 3 minutes to like flush the whole face with RET double bracelet style.
Yeah, cool, cool.
Mm.
So you ever hear something called Parsonage-Turner syndrome?
Not actually from. I
Okay,
feel like
so you
I'm
know what
remembering back from school that it's more about brachial plexus leading up
Yeah,
to the net. Oh, okay,
yeah,
here,
good call,
here,
man. All right. Give
there we
that guy
go.
$5, Ramona. He scored.
Yeah, that was good.
Um, but yeah, basically it's the same thing in the brachial plexus.
Okay.
So they're going to have it's viral, usually kicks it off. The patient we had a vaccine about 2 weeks before. I don't remember what type it was, in his arm, and excruciating pain, like do not touch me pain. The pain goes away in a couple of days, 3, 5 days, and then there's a palsy. Can't move the arm. It will generally affect the proximal muscles and not the deep muscles. I'm sorry, the proximal muscles, not the distal muscles. So you might lose triceps, but you're not going to lose the wrist extensors or the finger extensors. And so it's like, wait a minute, it's not following a nerve, it's not following a nerve root, but it's something where it's dead. And that is generally Parsonage Turner. Again, the same problem is somebody comes into the doc, they can't move their arm at all. MRI, CAT scan, lab work, rule out this, rule out. By the time they've ruled everything out, oh, it's just a palsy. What happens is it's 3 months, and now their arm has to get started waking up. This happened to be a patient of mine, and he came to me first. So not great video, but we have the RET. So I kind of do what you did here, Jesse. I put the RET right over the brachial plexus, and then I did the CET through the shoulder to get the blood going, just to get it circulated. Those were his settings, some radial, RET, but the CET we also had going on his arm. But I tell you, I was nervous because he came to me first. I'm like, this is Parsonage Turner, but I needed an MRI. I needed someone to sign off on it to make sure maybe I'm not missing some sort of spinal myelopathy or stroke or some weird sin thing I'd never seen before. It was like a bear to get him to see anybody quickly. By the time we got his MRI, and 3 weeks later, we were able to get his EMG NCV, because you can't do an EMG NCV, for at least 3 weeks after injury, and that confirmed the diagnosis. So anyway, I'm doing the CET on his shoulder, and the whole time I'm just holding the RET over that brachial plexus, just having him hold it over the brachial plexus, trying to get as much motor contraction that I can that's comfortable. This took 7 months. This took time. But we got him back. He moved away, but when he moved away, he was at 90% recovery. So this one took quite a while. We had the ground plate. I used the handheld ground plate at this time. So, and I think that's the best way to do it, to have the RET farthest away from the plate, then to do CET in the middle, the capacitive in the middle, and then the return plate farther away. I think that gives us the best depth of penetration of all three currents. Anyone who want to collaborate that in there, was the ground plate. And that was
Yeah,
it.
Don,
It was a Parsonage-Turner syndrome. But get these neuropathies in right away. I think that's the bottom line. TechR is the only win-back with the high EMS stacked together, is the only game in town for these people. I mean, in my opinion. Has anybody else seen anything else that can get these kind of results in a palsy or these kind of results in a post-stroke patient?
and I think that, like, absolutely not. There's nothing else that would do this. And the thing is, it's like you're not just using the modality to not just one that addresses muscle tissue, one that addresses nerve, one that's gonna address like the joint disorders that are happening. It's all just one modality at once. And that's
Yeah,
what's so interesting when you get a palsy like this, because you have to treat all those things. So with
exactly.
that, like, yeah, like I would love to know if anybody else has been using anything to get this successful.
Well, I don't think so. We've
I think so.
collaborated.
Yeah.
I don't know if there's anything in the chat. If somebody has something in the chat, put it there, please.
Yeah,
But that's
somebody
what's
has a
so cool about it.
question. They ask, what was the frequency of the visit?
For me, I was only
Hmm.
able to get that kid in twice a week because of where he lived. However, we
And
were able to
roughly
get
how
him
long were the
back.
appointments?
My appointments, I was only doing 8 to 10 minutes of tech heart. Okay. And then I
Wow.
would give him a spinal adjustment, chiropractic, cervical and thoracic adjustment in areas of joint dysfunction. But he was on Aclavir, he was on oral corticosteroid. Was he one of those guys that would have gotten better in a month anyway? Who knows? Who knows? But you don't wait. That's the take home. You don't wait. But he had about a half a dozen 8 sessions, and then he got it again about 2 months later.
Oh
That
my
was
God.
weird. And then it was just a few sessions, and it bounced right back.
Well, and Don, I think, you say you don't wait. I think when you have something like Tecker to use on them, why wait? Because there's no downside to it. It's not going to detriment or impact their treatment in a negative way from whatever else they're on.
You're exactly right, but it's just unfortunately, this is one of those cases where it's like, well, it should get better on its own. Well, again, it's just a change in the mindset of the providers. You know what I'm saying? Jump in, be assertive. I agree.
Yeah. We
Good.
do have one more comment from Mauricio who said, I did have a patient recently status post 1 year palsy, just applied my general knowledge on TACR 2 times a week, got pretty good symmetrical results. However, only treated one side. Now I know to do both. Did you guys run it through insurance or OOP at all?
Me, I'm an Tech Card doesn't have a billing code. I don't know where he practices, but in the States, because we have
Yeah.
international people, but in the States, Tech Card doesn't have a billing code. If you were to put it in to one of your time code procedures, like myofascial release or therapeutic exercise, that's a different animal. But Tech Card itself doesn't have an individual billing code. So I don't know. You tag it on to like 97110, Jesse, or 97140? Do you tag it in with that?
So in the clinic that I was treating in as well, same idea, like not a billing code for TechR. We were doing cash-based services for TechR therapy. So doing this like post-treatment, it was kind of an add-on to her treatment.
Yeah, and generally I think that's usually the way to go is you have those billing codes that are for the manual therapy, the things that you're doing to the patient, but the tech art portion of it is not covered under that. So you wouldn't want to bundle it under it either,
Yeah.
Again, it's there is no code for TechR.
right?
Anything else in the chat?
Not at the moment.
Not in the moment. Well, shall we talk about some TMD? What do you think? All
Let's
right,
do it.
Let's do
let's
it.
do it.
I do have a
Facial.
really I thought for a second, I don't know if you remember Justin Bieber had a facial palsy a couple years ago, and I was like, wait a minute, was it Parsonage Turner? But it wasn't, it was a different type of facial palsy. So I thought we could like pull in something about the Biebs, but wrong one.
Next time. Next time. We'll
Ryan
see. Yeah.
Seacrest, I think, was the other.
Oh, really?
That was
Okay.
palsy.
All
Yeah.
right. Well, we're going to have to get some testimonials
That's
and get a unit with those people. But yeah, Parsons Turner is pretty rare. I don't think it's super common, but
Uh,
at least
Bieber
you
had
know.
another pretty rare facial palsy. And I mean the same thing for somebody who's a singer, it was very, very difficult. He had Ramsey Hunt was the one he had.
Mm, Yeah, I haven't. That's a new one on me.
No, that one.
It's
Yeah, sorry.
it comes from the same virus that causes chickenpox and shingles.
Okay.
Yeah,
All right.
interesting.
Well, that's where the pain comes in, I'm sure, because they get into the nerves there. These things hurt when they first hit, and the pain goes away, the nerve just goes to sleep. So, but it could be what they call that Saturday night palsy too. Is it Saturday night arm? What's that called? Come on, someone's going to remember. When you fall asleep with your arm hanging over the back of the chair, right? There's a name for that one too.
Right.
But
That's
anyway,
most of the time with my arm above my head and I can't for like the
that's
first
the
7 minutes.
radial nerve.
Yeah.
Radial nerve compression.
yeah, but really, any of those palsies that don't go away, Tech R stacked with the high EMS and the tens is the way to go. It's really the only game in town that'll restore it. Immediately, it'll start rehabbing it. And if it's chronic, it's the only thing that's going to wake it up. And if there's a fascial densification in the area because there was injury, it's going to release the fascial densification, which is only going to help the peripheral entrapment. So it's just great. TMD, 75% of people have TMD symptoms at one time or another. Could just be, hey, I can't close my mouth today, doc. It's been 2 days like this, right? Doesn't have to be chronic type of things. And again, we talked about it's a myriad of symptoms: headaches, tinnitus, stiffness, fatigue, other joint-related pain. One of the highest proprioceptive centers of the body is that TMJ area, facial nerve area, and multimodal approaches are best. That's what the research says. But chronic TMD, like any chronic pain patient, they might need neuroscience education, you know? You got Jesse, you got a CBD person, CBT, cognitive behavioral therapy person you work with down there, someone that you refer your chronic pain people out to?
I wish. I wish. I do have great pain management groups by me, but I don't have a CBD person by me. Um, no, I work a lot with, I don't know if you know the Paley Institute. They're a large, like, worldwide organization. They do all my pain management work.
Mhm.
I wish. I wish.
All right, well, we're gonna have to make that happen because I mean that's where chronic pain, you need that pain journal and you just need someone to talk you through it,
Yeah, and I
and
guess
maybe
that ends up
that,
being my job anyway. That's kind of like,
yeah.
I tend to have, honestly, about 40% of my population, even in the type of clinic I'm in, is a chronic pain type of situation where they're seeing me weekly. And that's what
Hmm.
you become. That you become
Yeah,
without all the training in it. That's what you become.
there you go. Pretty soon you'll be a chronic pain coach. Careful.
Right?
No, but I love chronic pain patients. I love them. They need care, they need nutrition, they need exercise, they need win back, they need everything in my toolbox. They need chiropractic care. Yeah, can they be draining? Sure, but they need everything that I have. So I love that demographic, regardless if it's, of what body part. But we're talking about TMD, and you're going to have three different types of dysfunctions. You're going to have an arthrogenic dysfunction, where it's a range of motion problem. And then how are you going to figure that out? Examine it, take some imaging, maybe it's arthritic. It's going to be myogenic, which is a majority of them, some sort of myofascial muscular thing, trigger points, myofibrosis, or go back to the neurogenic. We've been talking about so far Bell's palsy, but that trigeminal nerve could just be really mad, and that's trigeminal neuralgia. Okay. And also have the facial nerve. So those are the types of dysfunctional classifications you're going to have with TM dysfunction, right? A little bit of anatomy. There's only one muscle, the superior band of the lateral pterygoid will actively depress the jaw. All of the other mastication muscles close the jaw. Remember there's a disc in there, right? And that disc is held in place by a very small ligament, the interdiscal ligament. When you close your teeth and you clench, you close, whether you're chewing or whatever, that condyle of the mandible goes right up into the temporal bone and it literally jams there. That's why the disc is so important. Um, and as little as 1 or 2, 3 millimeters between the teeth can offload that joint. That's why splints or dental appliances can just make that jaw feel so much better. And we're going to talk about that research in a minute. But the take home with that is know where your muscles are, and there are muscles that are going to actively depress the jaw, not just gravity, and that's your superior to your lateral pterygoid. There's no consensus on musculoskeletal tests for TM dysfunction. You have to palpate them. You got to palpate the TMJ. You got to do active and passive palpation. You look for pain, noises, restricted movement. You guys ever come across where the patient says like they hear it, but you can't hear it? Like it's not like sometimes like a clunk and wow, it's a big clunk. You can hear it across the room. Other times they're opening and closing their jaw and I don't really hear it. Does anybody else come across that? Not really? Well, and when that comes across my desk, my answer is to get the bell of a stethoscope and put it over the TM joint while they're moving around and see if I can hear the noises then, because the TM is right next to the ear. So it doesn't have to be that loud for them to feel it's loud. And you can always put your fingers in the ears, your pinky with the palm side, the pad, facing the TM joint. Guess what? There is a minimum opening, 40 millimeters in adults. If it's not 40 millimeters, it's not enough. Okay. We used to say three finger breaths, four finger breaths. It's 40 millimeters. And your lateral deviation should be 4-1. All right. If you don't have a 4-1 ratio, left deviation, left to right to mouth opening, they have range of motion deficit. So it's going to be an arthrogenic type of a classification. So if the left to right deviation is greater than 5 millimeters, that's also another sign of joint dysfunction. All right. So this is all TM assessment. Check the active range of motion, check the passive range of motion, left to right deviation. But we also know that you have to consider, is it TM or is it a headache? So you got to kind of figure it out. Is it tension headache? Is it facial neuralgia? Trigeminal neuralgia, it could be something, central. Doesn't have to just be local. Doesn't have to just be peripheral, or a variant of a migraine. So you have to look at all those things, as well as, are they clenchers? Are they bruxers? Et cetera, et cetera. Do they have braces? Right? Did they take any teeth out when you had your braces? Did they use a palate expander? Those are all things that are going to change how the joint opened and closed while they were developing, which is going to lead you to TM problems. So the examination, real simple, range of motion, we talked about, palpate it. And then you have to look at the primary and secondary mastication muscles. You got to look at the cervical spine, the traps, the strap muscle, the longus colli, all of those, the the cervices, the deep muscles for what? Trigger points, adhesions, myofascial dysfunction. The usual things, but you got to check them all. Just can't go to the, pterygoid, medial and lateral, buccinator and masseter and temporalis and say, oh no, you got to check them all, And the cervical spine is a huge issue with TM. So, in fact, we know the branches of the C1 and C2 posterior rami reflex back into the trigeminal ganglia. So that's why people with TM problems, TMJ problems, TMD, may also have cervical spine involvement. I think, Jesse, you and I were talking about that earlier, weren't we?
Yeah, like some of your like assessment makes me think about like the type of client. So I maybe see like 2 or 3 clients that will come into me like this a year. They're a smaller client, like they may be very skinny, rounded shoulders. Their head's going to be a little bit forward. It almost looks like they have like a smaller, drawn back jawline. And sometimes these clients, they have a case of like a little upper thoracic scoliosis, or sometimes there's no scoliosis involved. But there are always patients that end up getting some sort of TMJ disorder as it relates to the thoracic and cervical spine. So they come to see me for neck pain or shoulder pain, but then as I'm treating their neck or shoulder, I see them on the table. They're going like this. They're like, mm. And I'm like, what's wrong? Like, did your jaw hurt you? And they're like, yeah, like I've always had this small jaw thing. My jaw pops. So absolutely that type of patient is what comes to mind. I think a cool thing to mention about that type of patient. So me, I'm not a TMJ expert, um, but I see it as I see like a wide range of clients. So with that type of client, they didn't come to me for TMJ. They're now like 3 or 4 sessions in, expressing to me they have a TMJ thing. I don't necessarily go right towards that area and treat that area. I try and stick towards like the primary treatment area, which for the most recent patient I'm talking about was more of like their thoracic and like shoulder blade area. And then I draw in exercises that relate to the TMJ. So something that really helped her out, she was expressing this TMJ discomfort she was having. She was also a bit hypermobile. So I was like, all right, cool, let's do isometrics. Good for pain, good for people that are hypermobile. So I taught her the isometric pose of we lifted her left shoulder in scaption. We put her into a tiny chin tuck and she was in prone. So I don't know anyone on the video that can see me right now, but this position, but prone. So in prone, we had cervical extensors active. With scaption, we had low trap active. And then giving a chin tuck, I was just giving some cervical alignment and gentle cervical flexion. And with that, I wasn't focused on, hey, let's get in here right now. Let's get in your jaw. I was saying, okay, you came to me first with shoulder pain, told me about TMJ pain. Let's try and activate low trap. So in that position, we held low trap. The win back has a very cool setting. It's called Rehab Plus. And basically, I was using Rehab Plus as a way to engage low trap. So what would happen is the current would pulse for a duration of time set by the protocol. We would pulse, we would hold the isometric. As the protocol turned off, I think it's about a 10-second turn-off time, we rested. And then we would come back in and we would run through this for about 6 to 8 sets of isometric holds. And that's kind of a great way to take on a client when you're not necessarily a TMJ expert. The client wasn't necessarily coming to you for TMJ symptoms to start with, but you were able to draw conclusions and you were able to use the win back to treat multiple aspects at once. So yeah, I think that's just a cool case that I had in my mind that relates towards the spine assessment, the thoracic assessment, the shoulder assessment, in terms of these clientele.
No, that's right on, man. And you know, if you ever want to go deep dive, the deep dive is check out some of Vladimir Yanda's work. He calls it upper cross postural distortion, which is a pattern of tightness and shortness upper traps, levator scap, tightness and shortness in the pecs, tightness and shortness in the suboccipital muscles, which drives you into that forward head posture. So releasing all and weakness in the mid and lower traps. So what you're doing is fixing what Vladimir Yanda, just made a huge studies about, and all the information's out there. So good job, man.
Yeah, no,
That
I
just
have to check into it. So I know I've
oh
heard all
yeah,
the upper cross and lower cross stuff, and I apply that to a lot of my treatments actually. Like always
yeah.
explaining why one thing can relate to another.
Because you're
But actually, I gotta
restoring
look into
people
him.
back to neutral alignment, to sagittal plane alignment. You're offsetting the nerves. You're giving them better function. You're giving them better posture, which means you're giving them better life. And you're not chasing the pain. You're chasing their lifegevity is what I call it. That's a whole nother animal, man. That's
Yeah.
great. Stay on it. So anyway, I digress. Guess what?
You
We're going to
guys
talk a
pump
little
me
bit
up.
more. I'm sorry, what, Andrea?
You guys pump me up.
That's it. We want to get fired up because
I'm excited to treat TMD now.
okay, well,
You
guess
guys are
what? Do you know
great.
how you're going to muscle test the different muscles of the TM joint? So it's real
Teach
simple.
me.
Open, close, lateral deviation, protraction, retraction. But the bottom line is you're looking to see if there's a tendinopathy of some sort. Because if the muscle is painful with resisted movement, it's a contractile element thing. If it's not painful when you resist the muscle in that direction, it's not a contractile element thing. It's capsular, it's ligament, it's something else or referred somewhere else or postural, like Jesse treats. So trigger points, don't forget trigger points, right? Win back with the high tens, knocks them out, knocks them out. But basically, your temporalis, you're going to get, they're all going to close the jaw. Here, you're going to get retraction. Medial pterygoid, in addition to, again, closing, you're going to get lateral deviation to the contralateral side. So if I'm pushing my jaw to the right and I'm feeling pain on the left, that's the left medial pterygoid barking at me. If I'm pushing to the right and I feel pain in the right TMJ, that's my right lateral pterygoid barking at me. Okay? And that tells you where you have to address your soft tissue work. And again, your masseter, in addition to closing, you get protrudes the mandible. So you get protrusion there, and you get lateral deviation, medial deviation. So how do you examine it? We talked about active and passive joint movement. Soft tissue, look for your trigger points, palpate the joint, listen for the noise, put a stethoscope on it if you need to. Your resisted muscle testing will dial you right in where the sore muscles are, the contractile element. Then you got to check for nerve stuff, right? The mandibular nerves in there and your cervical spine, like Jesse was doing, and a postural assessment. I would put that in too. Your big take home here, you could have an arthrogenic TMJ on the left, but a myogenic on the right. You're going to have to treat them differently. All right. So just be aware of that. The TM exam, if people want to watch it, we're recording this for so people who are home, pull it up. We're halfway through it, or like minute 45. You can watch the TMJ exam. Lateral deviation. When you lateral immediately deviate, the jaw should be slightly open. You want to start it close to an open pack position, not fully open pack, just about 10, 15 degrees open. And then you can really test medial lateral deviation, checking the pterygoids. Then you do protrusion, you do elevation, protrusion, and then retraction. And there you go. That's how you muscle test it. Then you can get in there and palpate it internally. You can also palpate it externally, but you can't get to the pterygoids that way. You can get down to the masseter, and I like to pinch it to get the medial pterygoid to just kind of work it. And way up top on the palatine plate, the pterygoid plate, you can get in there and get to the medial and lateral pterygoids, going to come inside the jaw. So people can watch that, all the things we're talking about. Right here, though, the angle of the jaw, I passed it. The stylomandibular ligament is often really, really tender when people have TM joint problems. It's not written anywhere, but it runs from the inferior angle of the jaw, to the styloid process. But when the jaw is working fine, that's not tender. So I use that just as a clinical finding on how the patient's progressing. So I encourage everybody to check the stylomandibular ligament. That's just something I found over the years. And there's just a review on that, what the muscles do. And remember the nerve, right? Mandibular nerve. Yes, Romano.
Don, before you move on from this, Dr. Harry asked if you could pull back up the trigger point slide.
I can do that. Quick, take a picture. Harry, come on, you got my email address. I'll be happy to email it. No worries. But thanks for tuning in, bud. He's from Canada, He's like, he comes on all the AMAs. We appreciate your support, buddy.
Yeah, he's got it. We can move on to the exam.
Okay. But anyway, the exam's there. And if anybody wants these videos, just reach out. Remember the mandibular nerve here's got one motor component and then it's got two sensory components. Okay. So palpate it. That might be hot. And what are we going to do for it, Jesse? The branch of the mandibular nerve, the trigeminal branch of the mandibular nerve is mad at us. What are we going to throw on it?
We're gonna high tens it, or we're gonna EMS?
You got it, baby. Ain't like it's Bell's palsy. No different. Yeah. No different. But we got the tools to treat it, right, Andrew?
Yep. High tens. You want to down regulate.
That's it. What do you mean by that? You want to explain that to everybody?
Go ahead, Don.
Oh no, Andrew, you're using big terms. When you use big terms, now you got to explain it. I'm not going to let you just drop fancy words and walk away. Down regulate with high tens. Come on
Down
now.
regulate. Anytime you ever get any sort of nerve issue, one of the things is that the perception of the pain. And so you want to essentially decrease the nervous system sensitivity to the pain to help reduce things like muscle guarding or muscle tone. So that way the muscles around the nerve, also that protective area, also the tone starts to decrease. And so essentially what you're trying to get is not only the nervous system to respond and desensitize, but you're also trying to get the tone around the nerves to also decrease. And so those are two things that you want to look for. The last thing is the nociceptive input, meaning the pain. Oftentimes with TechR, like one of the great things I love about it is that by using things like the capacitive and the resistive currents in combination with the high tens, you're also getting not just increased circulation into the area, because once the tone also starts to decrease, you're also getting a decrease in mechanical compression in the area. And so, as Dawn and Jesse have talked about, they've used a wide variety of settings on the TechR, CET, RET, high tens, and the EMS. All of those functions work on different types of structures. So, nerve, muscle, deep into the joint capsule, and all at the cellular level. So, hopefully that was good enough for you, Don.
No, Andrea, not only was that great, that is a perfect reason why you can take pain management and then throw in what Jesse said about that other setting, the muscle back or the rehab plus setting. We can go right into rehabbing low, medium, high level functional patients, right? With the wind back. So yeah, it's great for pain control. Now we're stimulating the muscles. Now we're strengthening them. Now we're creating new neural pathways, neuroplasticity, and that's what's going to get your chronic pain patients from not being chronic pain patients anymore, let alone the person who's just hurt. Because now we're developing neuroplasticity, which is Ramona's wheelhouse. Right, Ramona? You're all over neuroplasticity.
You know it, Don. And I'm just making a note here because I want to clip this piece where you get so passionate about it so that we can have a great little video of you later.
All right, we'll figure it out. But anyway, thanks. That was perfect, Andrea. And I think that you're very, very well said, really. And it was very applicable. Very applicable. So thank you. Some
We did
studies.
have a question in the chat earlier, and I don't know if you're going to touch on this later.
Let's do it.
But it was about Mauricio asked if he's been suggesting for his patients to see an orthodontist to make sure that there's no major structures that need to be adjusted with braces, etc.
Yeah, we'll get
Is
to
there
that.
something? Okay.
We're going to get to that. Hold on that. Good question, though. We're going to hit it. Okay. So a few more slides. Ultrasound's been shown to be good for TM, not nearly as good as TechR, and TechR is not ultrasound. But there's other things we can do. What about photobiomodulation and splint therapy? Splint therapy increased maximal opening, right? Over 45. I'm sorry. Increased it if it was under 45, reduced VAS, reduced frequent episodes. Okay. So there is some benefit for splinting. And I believe a lot of it's because when you're splinted, you're not jamming that condyle up the disc into the temporal bone. All right. What about they did occlusal splints, low level laser, and drugs? VAS scores were increased, both laser and appliances. Laser and appliances combined with drugs proved to be effective for pain rejection and the myogenic classification. All failed. Significant improvement in mouth opening or muscle tenderness. No statistically significant reduction in pain with drugs only. So drugs are out. Windback's definitely in. Splints and laser, maybe. You got to be careful about lasers. It's got to be low level. You don't want it near the eye, or class 4, and you don't want it near the thyroid, or class 4. Okay. So photobiomodulation with manual therapy, we're able to decrease pain and mandibular movement. So we're doing manual therapy with Windback. So it's going to get even better results. And there's anxiety and pain. Results showed therapies improve functional capacity. So we got to get in there, guys. Manual therapy is good. All right. And it's going to be even better with TechR. We're going to show that in a second. Combination of photobiomodulation and manual therapy did not promote, they didn't have a synergistic effect. All right. So let's just use the manual therapy primarily. I use a light patch because it's safe by the eyes. That's just what I do. This is this patient here, Jesse, is a motor vehicle accident. She did not go over the back of the headrest, and she happened to mention that, my TM, bothers me. Can you take a look at it? And so I'm using the gloves with the bracelets, and I'm just working all of those muscles in through there, manually releasing any adhesions, a combination of pin and stretch, checking that stylomandibular ligament, and just kind of working where those adhesions are. She came off the table and was like, wow, can you do that on my other jaw now?
And the
And
thing is,
now it's like, and she goes, hey, what am I gonna, can I get that every time I come in? He goes, look, we tried it today. Let's see if you're gonna need it on a regular basis. It's not a covered service. We'll talk about it, you know?
and I think the cool thing is, like, obviously Don is showing like some more advanced techniques as it relates to the TMJ, and a lot of these times clients are going to get referred to a TMJ specialist, and like how many of those are really out there, right? But when it comes to WinBack, you don't have to be a TMJ specialist. Like if you could just start with, okay, let me loosen up the muscle. I don't even have to go interior. I could just do CT work and try and put a deeper current. Then I'm gonna hit those deeper areas. Maybe I'm not manually stripping and like freeing fibrotic tissue, but I know the current is getting there based on the depth of the frequency.
So
So
here's the
obviously,
thing, Jesse, that you're exactly right. I'm going to challenge everybody, number one, to be thoughtful. Number two, if you release the myofascial stuff, the patient's going to have significant improvement in 8 to 12 sessions. Sorry, guys, it's not 3 times a week for 3 months. If it's a myofascial component primarily and secondary arthrogenic or neurogenic, they will have significant improvement in 8 to 12 sessions, just by what Jesse was saying. Get in there and release all that stuff. Then you fix their posture. Then you add the high tens and the high EMS, you're going to get even better results. So, number one, treat them like this. If they're not better, or if they know they grind at night, the dentist will tell them. Dentists can see flattening of their teeth. If the dentist isn't saying, hey, you're grinding at night, they may not really be grinding, but some people can tell and some people can feel it. But first, just get in there and work them before you send them out for an appliance. And in my humble opinion, what did we talk about initially? An appliance separates the teeth just enough so it doesn't jam up the joint. Have them go buy an El Cheapo, heat it up, boil it mouth guard, and try that first for $20 before you buy an appliance for $750, unless it's Jesse's patient that had the retracted jaw or the protracted jaw. That's an alignment issue. That's an alignment issue. You need an orthodontic alignment. But if you just need a spacer, don't get a shock doctor. Don't get the $30 one. Get the $5, $10 one we had when we were kids that you heat up and boil and bite on, and let them try that. And that's your protocol. That's what I do. And it works great. Little oral facial rehab. I want to try to bang these last couple of slides out. So let's get to those questions in a moment. First is, if you want to strengthen those muscles, you want to open the mouth along a central line and give yourself some isometrics, right? With gentle overpressure, 15 to 20 BID to TID. If it's tight and stiff, you want to lengthen it. Tongue goes up the roof of the palate, not against the teeth. And then hold it there 10 minutes. Ooh, that's a long time. 3 times a day or more. All right. That's just release. TechR is going to release it better. I have not done these exercises with TechR at the same time. I think that would be way cool. Hypermobility again. Tip on the top of the palate, hold for 2 seconds, relax, 15 to 20 reps, 2 to 3 times a day. So those are simple oral facial rehab exercises any of these TM patients can do. Maybe next time I'll have some data on stacking TechR and high EMMs with it. Real quick, Andrew, we had asked about adjusting the TMJ. Remember that interdiscal ligament I don't like to hit it hard. I usually do the myofascial work first, but you have to remember it's a hinge joint. So you have to adjust both sides. Maybe not simultaneously, but I generally do. But you have to adjust both sides because it's a hinge joint. You can't just adjust or manipulate the dysfunctional side. You have to treat them both. And it'll be aesthetically good, Jesse, too. But that's how you can treat both at the same time. If there's a lateral deviation, you can favor one side. Use a thenar contact right on the mandible, and then you can drive the jaw left and right to just manipulate it, mobilize it, or you can, again, slight mouth opening, right? 10, 15 degrees. You want to give him that open pack position. He's got a deviation. You hold him away from that deviation as he opens up. So you don't let it get that jog left, right? So as he's opening, you guide it straight. You guide it straight. This would be money with bracelets and high EMS. Because now we're going to get that re-education of the nerve fiber. So there's an adjustment, right? I can get my pisiform on it and adjust it straight down. There you go. An impulse on it. Now watch this guy's mouth. He's just going to open, and I'm not even going to impulse. There it went. Right? So Andre, I would just start with that. And that's a great way to get the adjustment. And we're just demonstrating. But if it was really locked, yeah, you got to stand up and get that toggle on it, that real high HVLA, super fast. Yeah, so those are just some adjusting techniques. I wanted to get those in. And again, that trigeminal nucleus. See, Jesse, this is why that cervical spine is so important. That reflex right back up here, those C1, C2, C3, posterior rami, they go right up. So what you're doing is so cool and so key by assessing the cervical and fixing the cervical spine. Different pain modules, vascular, could be in their head. All pain's in your head, but where's it coming from? We're mostly myofascial. We fix the myofascial, and a lot of this other stuff calms down. Topicals are great on the cervical spine. Don't use them by the eyes and the ears if they have counter irritants, right? Menthol impacts those TRPV1 receptors. It works. Multimodal treatment of TMJ, exercises, localized modalities. Wim-Bac's the best. Maybe photobiomodulation, ultrasound, old school. Manual therapy with myofascial release, relax the hypertonic muscles, increase ROM, proprioception endurance. There you go. Cranial cervical region, treat it. Cardio, they don't have blood, they can't heal. Occlusal splints, I would not use it as a front line only if they have a confirmed bite issue. And the dentist would know that, but I release the muscles. And if it's an issue, we tell them to get an over the counter. If that doesn't work, they can pop for the $750 splint. This reference is from these two resources. So they recommended medications. I'm going to put them on nutraceuticals and topicals. Okay. Shut down the inflammatory cascade. And cognitive awareness and self-help. Jesse, I'm sending all of my CBT patients to you. You do remote therapy from New Jersey. That's what I want to know.
I'm in Florida, Don.
Well, but do you do remote? Zoom it, baby.
Anyone that wants to come my way, that wants to get a little help, I would love to help any patient that would love to see West Palm Physio.
There you go. So that's pretty much it. We went a little fast at the end. Ramona, Andrea, any other questions?
No questions here, Don.
Yeah,
No, we got through everything in the chat.
yeah, that was a great summary there at the end on. And Jesse, I think that was a good shout out. I mean, if you got patients that from New Jersey who have to go to West Palm, I think that's not so bad, right?
Yeah, they'll come see me in the winter.
No.
Right now, it's a little too hot down here. I think the humidity was like 80% today. So
Actually, we do have one question in the chat. Would you use the fractal headpiece?
For TM, I find I don't need it personally. I can get plenty of authority with, the RET and the high EMS, and it's a pretty sensitive area, so I don't have to crank it up. I don't know, Jesse, your comments?
The fractal headpiece, the three-prong piece they're talking about?
No, the fractal
No,
headpiece is the one with all the high tens
the
piece.
tiny little
Oh,
electrodes. Yeah.
yeah,
Yeah.
so I guess I'm more using that for deep trigger points. Um,
Yeah, that
Yeah.
because
would be a great one.
that's such a sensitive tool for some of the facial regions. I'm sure you could set the settings low. Just my experience with it more for deep trigger points.
Yeah, I agree
Yeah,
with
but I think if they can't get
Yeah.
past 10 or 15% with our fingers and the applicators, that's already given them maxed out. So I don't know. You
Yeah.
can try it.
I would say, in terms of the fractal headpiece, I would be very wary of using it around highly sensitive areas surrounding the nerve, because patients will then come back and tell you it feels like fire ants or like a bee sting. You'll really inflame the area. However, for trigger points, maybe in the regions that Dawn showed previously in that slide, like for the upper trap or the levator or the rhomboid, like that would be great areas to use the fractal headpiece. Personally, I would probably not use it in areas around the face, just because of some of the things that Jesse mentioned earlier, the sensitivity in that area.
yeah, when you think about
Henry, I want my slide back.
no, I mean, when you think about the fractal head and how many tiny, basically you have such a cluster of electrodes in one tiny area that, you have to make sure that you're treating an area that's not hypersensitive just because it's going to have
Hmm.
such an intense reaction.
Hmm.
All right. Anything else out there?
That looks like it.
Hey, I,
Anyone?
I
Just,
just I just want to say great questions from our participants today. You guys really made this webinar come to life. So we appreciate you guys being on and asking questions.
Keep doing it. That's what we're here for. We want those questions.
Andrea, real quick, you had mentioned about, the temporalis muscles super thin, but it's under your
Mm-hmm.
hair. So how are we going to do trigger points? And it goes all the way behind your ears, guys. If someone's got a
Yes.
temporalis issue and they got pinpointed pain where it attaches to the condyle, you can't just rub it there. You got to go to those fibers behind the ear. How are we going to get Tekar on those guys?
Great question, Don. I think, one of the methods that's really unique that you can try is if you are wearing nitrile gloves with the bracelets, one of the things that you can do is actually wet the hair, then use lotion. And that will help to conduct the current in the area, but without being uncomfortable to you or the patient. So if you find that, your patient isn't bald and isn't making your life easier in that way, and they have a lot of hair like me, and you want to work in through the temporalis or even through the like suboccipital region, you're having just a really hard time, or even in through the like cranial sutures, then what I would say is to use that wet method. So apply some water, use some lotion, have the nitrile gloves, and then wear the bracelets, and then you can go in and do your manual therapy from there.
Cool. Yeah, because I just get in there and work them out manually.
Hmm.
But no,
I
that's
have
great.
I have a patient that hates when I get any lotion in her hair. She would hate that method.
Yeah.
Well,
Yeah.
it's
But
like
it's definitely could be useful to get to those more under the hair areas.
If they're
you just
willing.
have her come the day before she
Yeah.
goes to the salon. That's
Yeah,
what you
right?
do.
I think that, yeah, Jesse, I think that that's come up before, right? Is that sometimes the best way to do it might not agree with the hairstyle, but if you can get him to come in the day early, that's it.
Yeah.
Okay, well, I think we've reached the end of this time. So thank you everybody for joining us for this month's Win Back Ask Me Anything. A huge thank you, of course, to our leads, Dawn and Jesse, Grant, Andrea, for being here, for sharing your expertise and your clinical perspectives today. It's just one of the greatest strengths of these conversations is the opportunity we have to learn from all the different disciplines and approaches while always keeping in mind what we're all here for, to make people feel better. So we hope today's discussion gave you practical insights, new ideas, and a deeper understanding of how tech art therapy can be integrated into facial recovery and rehab. Thank you again to everyone who joined us live. The questions were awesome. The discussion was great. If you're listening back on the podcast replay, we're glad you're part of the Win Back Academy community. And be sure to join us for our next AMA, which will be July 22nd. And Dr. Grant Headley will be leading that one, discussing functional medicine, the biopsychosocial TECAR approach, and exploring how TECAR therapy can be integrated into a more holistic model of patient care. So that should be a really interesting topic of conversation, something that's a little out of the box for us, and we're super pumped about it. Thanks, everyone, and we'll see you next time.
Good night. Thank you.
Good night. Thank you guys.